very much, Elizabeth. That was a fantastic talk before. So when we talk about rapid response systems, I think it's always important that we put it into context of what we're doing. So what is good for a 250-bed hospital may not be good for a 500-bed hospital. So one glove doesn't fit everybody. So to give you a background, our hospital, we're a 400-bed hospital. We're on the edge of the central business district. We're tertiary referral, have about 50,000 admissions a year, and we only have, well, only 19 ICU beds with about 1,700 admissions per year. We have what I call a rapid response system, okay? It's not just about the team. The team's important. That's an ICU nurse, an ICU registrar, medical registrar, and we also call in anaesthesia, ED and cardiology for other calls like cardiac arrest, threatened airway, or calls outside the hospital where we need a bed. But it also includes the fact that we get data on every patient. We have a very complex database. We produce routine reports, and that means that every week one intensivist looks through every call that has happened in that past week and then brings a summary of that back to the consultants meeting on a weekly basis. We also undertake routine analyses, usually every 3 to 6 months. We use it for publications, and we also use it as a way of educating people in the hospital. So to give you an example, this is just an example of the data sheet. That's only one page of the data sheet, but this is a report that we would send out to every ward, and used to send it to every unit, but we didn't get much response from the units, so we send it to every ward, and it tells them how many calls have occurred and so forth, but it gives a breakdown of every single Met call and what we thought was the problem. So it is feedback. And in more recent times, our people have also been going to the ward to present this and get the feedback from the wards itself. As I said, we've used it for lots of presentations and publications. It's useful because you have to keep analysing the data if you're going to get some value from it. Our staff also run deteriorating patient workshops. These are scenario-based education, a couple of these a year. Roger Smith, who's one of our research coordinators over there, did an analysis, and we know what the calling criteria is: tachycardia, hypotension, hypoxia, but it needs to be linked to what the final diagnosis was, because if you get called to a low blood pressure, then you know instantaneously that it could be X, Y or Z. The same goes that if you get called for tachycardia, it's going to be AF most of the time, and you have these algorithms of treatment in the back of your mind. So when we first started this goes back a long time now, we noticed that a lot of calls were happening early on because of hypoxia, low saturation. In fact, interestingly, low saturation really wasn't one of the original calling criteria, but we got called for it anyway. And often when people went there, they found, oh, no oxygen connected, or the mask was on and it was turned off to the wall, or nobody had done any troubleshooting or done the initial thinking about what needs to happen. And on the other hand too, we found records of saturations in the 70s and no one had escalated those calls. So at that time we partnered with the Department of Respiratory Medicine. We developed an education program specifically for the wards to enlighten them as to what saturation means, how to get a good reading, and basically what you should do, as you're calling the Met or before you call the Met, to optimise the care of that patient. Probably happens to you too, but one of the calling criteria is for prolonged or recurrent seizure. But as soon as the patient hits the floor, the buzzer goes off and you get called for every single seizure, whether it's a partial one, whether it's on neurology or on general medicine. So we thought, well, we needed to do something about this, and we analysed the calls and we came up with a protocol for the hospital. It doesn't project very well, but we defined it into stages. And we said, look, in the 0 to 5 minutes, that your priority here is just to protect that patient. Don't try and do anything, just get them into a safe position. Don't put your fingers in their mouth, and protect yourself. In the next 5 to 10 minutes, if things are still not happening, well, you need to get some sort of drug into them. And taking work from particularly paediatrics and things, we've been trying to go down a buccal midazolam route. And if the seizure is going for more than 10 minutes, or it's actually having repeated ones in front of you, well, this is really where ICU needs to step in. We need to use more complex anticonvulsant medications and probably retrieve that patient back to the intensive care unit. But the majority of seizures stay on the ward, and it's really getting people comfortable in order to manage it. So we were able to produce this and promote it throughout the hospital. Another one was we were amazed at the number of times we had to go to the ward to give naloxone to patients because of hypoventilation or altered conscious state. So we thought we needed to do something around this, and it turned out that on analysis of the data there were two sort of sets of patients. There were what I call the opioid naive group. Those people come in, they have an operation, and it usually occurs in the evening after they get back from theatre, but we give them a dose of naloxone and everything's all right. But there are patients there, those who have self-administered narcotics, people with renal failure, all those people on OxyContin or Targin before they come into hospital. And you'd be surprised the number of people that come into hospital with a patch still attached to them that no one knows about. And then they're given a PCA. So we give them the naloxone, and people forget that naloxone wears off before that narcotic wears off. So we said for this group of people, you give the naloxone, but you also give an intramuscular dose of naloxone before you leave the ward, and tell them, you know, this should last you for a little while, but go back and check the patient in 1 to 2 hours to see that things are still effective. Another one is the management of tachycardias, atrial fibrillation. It seems to be a very common reason that people get called to the wards, and everybody does something differently. There's no coordination. So we actually thought we'd try and develop, it was meant to be a little app that went on the phone for the residents, but having no app development skills, it hasn't got to that stage yet. But we told them, well, look, this is the sequence that you might use. A beta blocker, you could use some verapamil, amiodarone and digoxin probably a little bit further down the line, but give people the skills or suggestions what they could do as before you actually get up to the ward. The other interesting thing, and why I got a little concerned about the number of MET calls that everybody has been doing, it's increasing certainly throughout Victoria, and I suspect throughout Australia, that we're just having more and more calls. We're seeing many occasions where multiple calls are happening, and you know, I've seen data from one hospital where there have been 5 simultaneous MET calls. And how do you develop your teams around it? But when we get to the call, we look to see whether there is an NFR order already present. And as you can see from this slide here, that this is only in 2015. I'll show you some earlier data. We were running around 12% of the calls had a valid NFR order. And when we started the MET, you know, the idea was to reduce cardiac arrest, reduce hospital mortality, and reduce admissions, unexpected admissions to ICU. But with a lot of NFR patients, it's really just symptom management. It's not we're going to actually improve their hospital outcome. But we're now up to 35% of the calls that we attend have a valid NFR order. Now, a few years ago, we noticed this trend going back 2009, and we're using a technique, you've probably seen other people use this, called interrupted time series analysis. And I think it's a very useful little tool to give you a visual idea about what was happening. So when we started noticing this back in 2009, there's quite a scatter, but there was an increase in calls. I then actually went to the ward and I said, look, you know, we're not really going to improve the long-term outcome. Yes, we might help with the symptoms of these people, but wouldn't it be better if you just gave us a telephone call, got some advice, and when we got time, we'll come up and see the patient. Rather than calling the Met, we have to drop everything, almost stop the ward round on occasions or doing it, and go and see this patient that I think sometimes the ward team really needs to see. And they took it on board, and you can see that what happened was that there was a steady reduction from about late 2012 down to really late 2014. And we got down to only around about 8% of those calls were having Met calls. Unfortunately, what happened then was that the hospital changed the NFR form. And you could actually tick a box which said, yes, not for a CPR, but still stay for Met calls. And I got trumped, and as you can see, it just started to rise. And from that other graph, you now see that we're back up to the 35% rate of the calls. I don't know how we're going to cure that, but we do need a light Met, that is just a telephone call for advice, or we do need the general teams to sort of step up and manage these patients on the ward. Other hospitals have actually devolved the care of Met calls to their medical units. The ICU is only as a backup, so yet another suggestion in order to manage that. I mentioned before that we looked at the outcomes of the final diagnoses. These are, if you like, the calling criteria. The commonest one has been altered conscious state, and you might be surprised, but it is narcosis that's probably the most common of those in there. Primary CNS event and seizures. Hypotension in orthopaedic patients coming back from 6 p.m. until midnight for us is a big cause, and the rest. But as I said, having linked that to what the final diagnosis is gives people a heads up as to what they can actually do. What other things have happened? Well, some of the registrars suggested maybe everybody gets together at 11 o'clock at night, the ED, the medical, surgical registrars, the ICU people, and they just talk about who they are so everybody knows who's on call, and they talk about the sick patients and they delegate a little bit. The Alfred has a system called the Hospital at Night, which is even more sophisticated than that. I think you need to have the input of senior clinicians, and I think Andrew's talk before was exactly that. The head of unit said you must do this, and he followed up on it, and that was very important. I think you need to have solutions that are tailored to your environment. We kept up a code blue and a Met call because there are some places that aren't skilled enough to know about Mets and they just make a call, like outpatients and rooms. And there are times we need a bed. We don't carry a bed to Met calls, but sometimes outside at the pond or somewhere else we need it. And you need to know what to do in and out of hours. And I put down there union issues. This is very interesting that when the Met first came in, people like the orderlies and the administrative staff should be able to make a call. Someone's collapsed, I'll call a Met. But when we went that way, the union said, only if you give us a pay rise will we actually let our members call Met calls. So we had to drop that entirely. It was just totally unexpected. So in summary, I think it is important. You need to look at the data. You need to have review of that data very regularly by senior people, and you need to be prepared to make suggestions as to how to improve the care. Thank you very much.